Alright guys, this is a particularly tough area of pharmacology because knowing how these lipid-lowering agents function requires remembering and understanding physiology behind lipid metabolism. Yeah, that's tough. So let's work through these drugs starting with the first step, ezetimibe. Ezetimibe inhibits the absorption of cholesterol into the enterocytes by blocking the cholesterol uptake receptor on the intestinal brush border cells. Now, how does the decreased absorption of cholesterol lead to a drop in LDL? Well, the liver is going to increase its LDL receptor expression because it's going to need to start pulling in LDL from the systemic circulation because the gut GI brush border isn't absorbing any cholesterol for the liver to make stuff with. Now, ezetimibe has no effect on HDL or triglycerides. The toxicities associated with this drug include diarrhea, because if you can't absorb it, it's going to stay in the gut, and cholesterol has an incredibly high osmotic gradient, so it's going to pull in water, and these patients will be spending a lot of time on the toilet. Hepatitis is kind of rare, but it can definitely happen with ezetimibe. You have to be on the lookout for this. The drug is metabolized primarily by hepatocytes. It can cause hepatitis, which means that you need to be on the lookout for an elevation of liver function tests, AST, ALT. Now, if you inhibit cholesterol absorption, the body can still make it. Cholesterol is a sterol derivative synthesized by a bunch of steps that you don't need to know, but you do need to know one, the rate-limiting enzyme. What am I talking about? I'm talking about HMG-CoA reductase. Now, what drugs inhibit this enzyme? The HMG-CoA reductase inhibitors are the statins. These are the big-time moneymakers. You have to know these. Now, how do statins lead to the reduction of LDL and triglycerides while also increasing HDL? So LDL is a low-density lipoprotein that's incredibly full of triglycerides. It's also incredibly full of cholesterol. Now, if you block the rate-limiting step in the hepatic synthesis of cholesterol, the hepatocytes are going to be like, what is going on? Let's compensate by increasing the expression of the LDL receptor. By increasing the expression of the LDL receptor, the hepatocytes can now take up LDL from the circulation. This leads to a reduction of LDL. Remember, if the liver is inhibited from making cholesterol and therefore LDL, it's just going to take it up from the blood. The end result is a drop in the amount of circulating LDL. Now the liver will also start to produce more HDL. This is going to help return cholesterol from the peripheral tissue. It's also going to help bring triglycerides out of the peripheral tissue back to the liver because it senses low levels of LDL. Now, the side effects of statins will be on your exam. People take these all the time, and they have the side effects all the time. Hepatic CYP450 enzymes metabolize the statins. So it makes sense, metabolism of statins can cause damage to hepatocytes. Make sure, again, you look at the transaminases, particularly ALT. Now, the risk of hepatotoxicity increases when you use this in combination with fibrates or niacin. Now, why is that the case? Fibrates and niacin directly inhibit the hepatic uptake and catabolism of statins. The risk of hepatotoxicity increases in direct proportion with the amount of fibrates and niacin because it decreases the rate at which statins are cleared by these CYP enzymes. Another super high yield fact is rhabdomyolysis. It brings in the pathophysiology of excessive muscle breakdown and its complications. That's a great question. Be on the lookout for a patient on a ton of drugs, including statin and a fibrate, presenting with muscular pain, weakness, and dark brown urine. They might even be nice to you and give you a urine analysis that's positive for myoglobin, remember, or elevated serum levels of creatine kinase. This is all due to muscle breakdown liberating these enzymes. But don't count on that. That's way too easy. Be on the lookout for someone on statin or niacin or fibrate with muscle pain and weakness with dark brown urine. Now, one more thing that's probably the most important for you to know is that all of the drugs on this page, statins are the only ones that actually decrease mortality. And do they decrease mortality in any type of patient? No, they decrease mortality in patients that have coronary artery disease. Now let's focus on the next one on the diagram. Right here we have niacin. Niacin, or nicotinic acid, this is a complex B3 vitamin that is converted into NAD or NADP. It directly inhibits lipoprotein lipase. This leads to the decrease in the amount of circulating triglycerides. Why? Well, because if you can't liberate triglycerides because you're inhibiting lipoprotein lipase, there's going to be less of them around. In hepatocytes, niacin also inhibits the synthesis of fatty acids. Without fatty acids, the liver cannot make very low density lipoprotein, so we decrease VLDL. What is VLDL a precursor of? Look at this pathway. It becomes intermediate density lipoprotein, and it eventually becomes LDL. This is how niacin leads to a decrease in the amount of circulating LDL. Niacin, fortunately, also helps increase HDL. How does it do this? Well, it inhibits the liver from reuptaking HDL. Now, the side effects are rather unique, and you may have experienced them if you've ever drank a 5-hour energy shot because it's loaded with niacin. So what happens is that niacin induces the synthesis of prostaglandins. Elevated levels of prostaglandins dilate vessels and cause flushing, and sometimes they give you an itchy or tingling feeling. Now, a great way to prevent this is to inhibit prostaglandin synthesis. How do we do that? You give them an NSAID right before you blast them with all this niacin. This is high yield. This ties in 2 different pathways, 2 different drugs. Give your patients aspirin if the niacin they're taking gives them these side effects. How does niacin lead to hyperglycemia? Well, niacin can actually cause insulin resistance. So if cells aren't responding to insulin as well, the glucose levels in the blood are going to go up. Ready for another high yield one? What is this patient suffering from, besides other than a rather intense fungal infection? This is gout. Niacin directly competes with uric acid at the pumps of the proximal convoluted tubular cells. If the patient is taking tons of niacin, the pumps of the proximal tubular cells will now have to choose between pumping out niacin or pumping out the uric acid. They're going to pump out the uric acid or the niacin. They're definitely going to pump out the niacin because there's so much of it in this person's circulation. This is how niacin will drive up the concentration of uric acid and precipitate gout. Notice here there's the involvement of the digits, of mainly podagra, involvement of the big toe. And we can see that here in this image. The increased levels of uric acid are going to deposit in the synovial fluid of joints, here, mainly the big toe. This is always classically the first metatarsal phalangeal joint. How are we going to know it's gout? Well, we tap the joint and put it in the microscope, and you will see these. These are negatively birefringent monosodium urate crystals. All right, back to our diagram. Next up are the fibrates. As shown, fibrates increase the activity of lipoprotein lipase. This is actually going to increase the amount of circulating triglycerides because it's liberating triglycerides from peripheral fatty storage. Fibrates also induce the peroxisome proliferator activated receptor alpha. This is PPAR alpha. This is a transcription factor. So now we get the synthesis of more proteins that will help us in fatty acid beta oxidation. In this way, we can burn up all of these triglycerides that we liberated. PPAR alpha also induces genes responsible for the production of more HDL. It also reduces the synthesis of VLDL. Again, VLDL is a precursor of LDL. So we also decrease levels of LDL. Okay, we need to know the side effects. Again, fibrates inhibit the reuptake of statins, leading to an increased risk for myopathy. Now what about the cholesterol gallstones? The activation of PPAR alpha also does one more thing. It increases the synthesis of bile. And this can predispose you for bile stone formation. Now, we only have one more drug in this diagram, bile acid binding resins. We made a full circle back to the beginning. Now, bile salts are within bile. Bile salts are made in the liver from bile acids. The main one is cholic acid. Cholic acid is made from cholesterol, hence the name. Now, bile acid resins target these cholesterol-derived acids. They bind them up. This is why the roots of the bile acid binding resins resemble that of cholesterol. Check them out. It's cholestyramine, cholestyramine, and cholestyramine. Now, by giving a bile acid binding resin, you're going to inhibit bile salt reabsorption. The bile salts will be eliminated in the feces, and so will all the good stuff that bile salts help absorb. Remember, we normally reabsorb 95% of the bile salts, but if we're losing them into the toilet, then the liver is going to have to make more. As a result, the hepatocytes use all available cholesterol. Then they start expressing more LDL receptors because they need to take LDL out of the circulation. They need cholesterol. There's cholesterol within LDL. This is how a bile acid resin can help decrease LDL levels in the circulation. The only drawback is that this process also induces the hepatic synthesis of triglycerides, so there's going to be an increase in triglycerides. This is the only drug on your page that increases circulating triglycerides. Now, just like all the other drugs, this also increases HDL. This is high yield side effects. What are some side effects of these resins? Well, you're making someone eat an insoluble resin that tastes and looks like chalk. This can cause severe constipation. It's a thick compound. It's hard to pass that stuff. Now be careful, because if you lose bile salts, you're also going to have a decreased ability to absorb vitamins A, D, E, and K because they're fat soluble. You need bile salts to absorb fat soluble vitamins into the body. All right, guys, good job. Let's keep pushing. Let's move on to discuss some of the drugs used in treating heart failure. The first group we will talk about are the cardiac glycosides. You may have heard this also called digitalis because it is derived from the plant that's called Digitalis purpurea. Here's a diagram that shows the different transporters on the sarcolemmal membrane of our myocyte. Now, which one of these does digoxin inhibit? Digoxin competes right here at the extracellular potassium binding site on the sodium-potassium ATPase. By decreasing the ability of this pump to pump potassium back in leads to the decreased efflux of sodium. We also decrease the inward restoration of the potassium concentration. We essentially deprive the other pump on the membrane from having an adequate driving gradient to push calcium out. Because we're trapping high levels of sodium inside, there will be no gradient to pump sodium this way and pump calcium out. The end result is an increased intracellular concentration of calcium. More calcium means more actin-myosin interactions because we can bind more troponin and expose the actin-myosin binding sites that we're interested in to increase contractile force. This sounds like an ideal drug for someone with systolic dysfunction, right? You bet it is. They need contractility. They need higher levels of intracellular calcium. Now, this is not the only mechanism of action of this drug, though. It is not yet completely understood, but somehow this drug increases parasympathetic or vagal tone through some mechanism in the brainstem. Now, increased parasympathetic tone in other places can lead to some of the digoxin side effects. For example, in the GI system, this leads to nausea, vomiting, and diarrhea. That's no good. Increased vagal tone to the heart can actually lead to excessive depression to the point where we can depress the SA or the AV node. It is very important that you be careful. You do not want to drop cardiac function excessively. The ability to do this, though, can be helpful if you do it right. If you depress AV node function, you can actually use this in the treatment of atrial fibrillation. Why? Well, when the atria are fibrillating, we do not want every single wavelet of depolarization from those fibrillating atrium to make it to the AV node and make it all the way through to the ventricles. So what about the blurry yellow vision? This is a big one. Well, this is because the rods and the cones in our eye that are responsible for taking light and turning it into a signal for your brain are dependent on potassium. Digoxin can inhibit the sodium-potassium ATPase on these rods and cones. This disturbs the normal potassium concentration and interrupts normal signaling because rods and cones mainly use potassium to alter transmembrane potential. They don't use sodium. This is how you get the blurry green color vision associated with digoxin toxicity. So how does digoxin lead to hyperkalemia? It prevents the sodium-potassium ATPase from pumping potassium back into the cell and sodium out. The end result is an accumulation of potassium in the extracellular environment, and we increase sodium in the intracellular environment. Another thing is that we also increase calcium inside of the cell. It is this accumulation of sodium and calcium that can shift the transmembrane potential to a more positive value. We have more positive ions inside of the cell than normal. Shifting our transmembrane potential is dangerous. We are now a lot closer to the depolarization threshold. This is how we are at increased risk for depolarizations, and we call those arrhythmias. If we're close to threshold at all times, firing early is a definite possibility. Now, we discussed the toxicities. There are some things we can watch out for so that our patient won't have toxic levels of digoxin. Number 1, digoxin is excreted renally. Watch out for anyone with changes in their creatinine. Remember, if you can't clear digoxin, it's going to accumulate in the blood. Digoxin competes with the potassium binding site on the extracellular part of the sodium-potassium ATPase. So if the patient is already very hypokalemic or low potassium levels, there's not going to be very many potassium ions to compete with digoxin at the pump. This can exacerbate the degree of blockade. Another thing is that digoxin binds albumin. But so do other drugs. What are the other drugs that bind albumin? Verapamil, amiodarone, and quinidine. So if a patient is taking both of these drugs, because they probably are, because they probably have some serious heart problems, you can guarantee that one of these drugs is going to be competing with digoxin on those albumin binding sites. This is dangerous because you can potentially displace digoxin off of the albumin and increase the amount of free digoxin floating in the blood. Okay, so how do we treat digoxin toxicity? Well, first, you want to normalize the potassium levels. You want to have more potassium to compete for the potassium binding site so that digoxin will not have a very, very strong block of the pump. We can also give magnesium because magnesium is a key cofactor for the sodium-potassium ATPase to work. Now, if we're still worried about digoxin levels at this point, we can give anti-digoxin fragments. And this will actually directly bind the digoxin out of the blood. If all of this fails, then we need to set them up for a cardiac pacer until we can figure things out. Now, we need to use a cardiac pacer because the SA and the AV node can be so severely depressed from digoxin's ability to increase parasympathetic tone on the heart. A cardiac pacer is essentially just a catheter that they stick into the heart with an electrode on the end, and it sends depolarizations to mimic the intrinsic depolarization of the SA or the AV node. You stick it in someone's vein, you feed it into the heart, so you can send electrical impulses to trigger the rest of the myocytes to contract. And here we go with a flash quiz. Digoxin is removed from the body by blank excretion. We just did this. This is high yield. People actually take digoxin. People have renal dysfunction. Yes, it's removed from the body by urinary excretion. This is why you have to be very, very careful with someone that has an elevated creatinine because they cannot clear digoxin with the same ability that someone with normal renal function can. Super high yield. You have to know this.